Yeah. In my clinic, I treat a lot of MPN patients and I have some untreated ET patients. They're not even on therapy, but they ask me, hey, how about cell therapy for this disease? And, I know it's not indicated, but it made me think, do you ever feel, especially with new CAR NK products, do you ever feel that the lines will come up even more to the point where we'll have some safe product in the first line setting? Because you showed that the right now it's all relapse refractory, second, third line, or even later. But do you think it's feasible that this could eventually be first line, or we're still probably a little too far with the toxicities?
I think probably even more than toxicities, it is difficult to make it first line therapy that can't be offered everywhere. You want you want a treatment that everyone can get in the first line, because you want something that will, yeah, accessibility is I think probably the biggest limitation, but also clinical trials just haven't gotten there. So we obviously in myeloma we just saw two clinical trials that looked to move CAR T up to second and third line, and those were approved in the last year. And lymphoma that happened about 3 or 4 years earlier. Um, so I think it is coming. There are some trials in lymphoma that are already looking at first line, but those haven't been read out. And Dr. Zhang probably is more familiar with those even than I am.
Yeah, we do have a couple clinical trial that kind of consolidates the initial therapy, like high risk and stuff like that. So we try to do it for our high risk patients. But to answer your question, I don't think it's going to replace our job for undifferentiated patient. Like think about it, you have to wait for the cell to manufacture to get the treatment. So you're delay on that sense. And like upfront chemotherapy has a pretty good efficacy in B-cell lymphoma. It's very accessible. But I think for those high risk patients and people with MRD, like towards the end, if they have access to clinical trial with CAR T, I will highly recommend it. It will help the science, as I said, as well as them, because the relapse rates are higher. So if we can select those patients, it will be pretty amazing to see how they do. Yeah.
And yeah, just to double click on that, I think that we those high risk patients are the ones that we're seeing in myeloma also, getting being studied for for smoldering myeloma trials and things like that, to try and catch people before the disease gets really severe, in the hopes of maybe going from what was mentioned earlier as kind of long-term remissions to cures. So I think there is potential, but yeah, it would only be for a very small subset of people with these diseases, I think, in anywhere in the near future.
Well, it goes to show you how siloed I was because I wasn't aware of these consolidation trials in lymphoma. So it's very exciting that we're seeing these cell therapies even earlier. And you bring up a good point, Dr. Kelekar, that one thing that I know patients talk about a lot is if I have a precursor like CHIP and MGUS, like we talked about an hour and a half ago, like what do we do about it? And this could be a potential solution in clinical trials is that maybe we can slow down the progression of the precursor lesion like MGUS with some type of bispecific T cell or something. So more to come. I think that the cell therapies are going to be in all phases of disease, mostly in the relapse refractory, but very much could be in the precursor lesions.